We are recording now, so we will jump into the agenda. So we'll start with our welcome and our council business, which we just discussed, and some of the housekeeping rules and information. Next, we're going to get into program updates. There will be an at-risk diversion overview presented by Victoria, and there will be a methodology for at-risk presented by Jill. And then next, there will be an at-risk diversion training from Nora. And then the last program update will be the new transition escalation web form, which will be, it won't be presented by Andrea. Someone else is going to come in and present it, and I'm not for sure who, but don't worry, we'll have it taken care of. And then after that, we'll have an open forum for any questions or anything like that, and then we will close.
Hi, my name is Victoria Lewis. I am an in-reach coordinator, so I'll be providing today some information regarding at-risk diversion. At-risk has been presented in the past meetings, but I wanted to provide a little bit new and updated information today. So we're going to go over the purpose and goals for at-risk, definitions, how those members are identified as at-risk, model development and summary, a brief overview of roles from different agencies as it pertains to at-risk and implementation. Go to the next slide, please. So the goal of at-risk diversion is to ensure that Medicaid members living in the community and that are identified as at risk for institutionalization by the department have the supports and services that they need to remain in a community setting of their choice. This will include an additional outreach by CMAs and RAIs to support these members in the community prior to their need for institutional admission. So how are these members being assigned to a CMA and RAI? It will depend if they're enrolled in HCBS. Members enrolled in HCBS will be referred to the CMA, and non-HCBS members, they'll be referred to the RAI. Previously, as you all know, that TCMTC was a Medicaid benefit offered to only eligible Medicaid members that were in an institutional setting. So this benefit has expanded to include members that are identified as at risk, living in the community. It is to support them with a higher level of community-based support. Next slide, please. So at-risk is defined as a Medicaid program. It's not a Medicaid program. It's defined as a Medicaid member who lives outside of an institutional facility. So it's a Medicaid member living in the community and is identified as at risk for nursing facility institutionalization. At-risk diversion is a process which services, resources, and supports are provided to help an at-risk member remain in the community. And it's to remain in a community-based setting of their choice. And it is intended to assist with keeping them safe and out of the nursing facility. Next slide, please. So this is a new process. It is first of its kind in the sense of using research-based methodology to target members specifically. The at-risk determination and model will include certain characteristics, diagnosis, and/or behaviors that may lead an individual to have a higher risk of nursing facility institutionalization. More information on the methodology and the method for identification will be published on the HCPF Long-Term Support and Services website when it is approved. And CMAs, RAIs, members, TCAs, everybody will be provided information by the department as to why the member was put on that list. And this is to ensure that if there's a specific need or concern that put the member on the list, that it can be discussed with a member and that proper assessment of supports and services can be provided to the member. I also want to note that this is not a mandatory service, so members have the right to opt out or decline any at-risk support or services at any time. And I'm going to actually hand the next 2 slides off to Jill. She's a director of community living, and then she wanted to really quick give some detailed information about the at-risk model, and then I'll finish up after her.
Thanks, Victoria. Hi, everybody. Jill Schnodders, the Compliance and Innovation Division Director. And I wanted to talk through how we're identifying individuals for the at-risk list. Initially, give you a little bit of a sneak preview and talk about the process that we've been using for this. So first, I want to note that this methodology and process is part of our Department of Justice agreement. And so as part of that, this model has to be approved by the monitor and the Department of Justice. We're in that approval process right now. So some of the information on the next slide, don't go there yet, please, Jay, may change depending on those conversations, but wanted to start with that information. So how did we get to this model that we're working on? We took a number of steps to go through that process. First, as we initially got our DOJ findings letter related to transitions and diversion efforts, we went around the state and met with key stakeholders to talk about, what are you all seeing in the community? What are areas that we should improve on? Where do you think we could make the biggest changes? And as part of that stakeholder engagement, we also talked about what are the things that make people most at risk to go to nursing facilities. And what we heard from you all were things like not having a partner, behavioral health concerns, dementia diagnosis, multiple hospital visits, different factors like that. So we took that into account as we were thinking about how to build this model. We also looked at other states. As Victoria mentioned, this is pretty new. There aren't any other states that we know about that are building a model similar to this related to nursing facility diversions, but there are some other states that look at different data sources to provide targeted case management outreach. So we looked at those. We also reviewed literature. There's some literature out there that identifies what types of factors lead to nursing facility admission. And, not too surprisingly, those lined up pretty well with what we heard from you all through the stakeholder engagement. We also looked at the data that we have available. So we looked at of people that in the past that have been admitted to nursing facilities in Colorado, what were some common factors that they saw? Were the things that we identified through the stakeholder engagement and the literature present in those individuals that were admitted? And did some statistical modeling there to see which of those variables were significant in driving somebody towards nursing facility admission. We then took all of those different factors that we identified and used that to create a risk score. And what that risk score allows us to do is, rather than making an assumption about okay, it's anyone with a physical disability, a dementia diagnosis, and is not married, those are the people that are most at risk. What it does is it allows us to do scores and weight those things a little bit differently. So you may have a higher risk score because you don't have a partner, but a lower risk score because you don't have a dementia diagnosis. And the risk scores let us kind of balance all of those out to identify the people who are most at risk and provide that outreach. Next slide, please. So what are the things that are included on the list? So again, this is going through the approval process with the DOJ and the monitor, but we do know that this first bullet is the criteria of the agreement. So everybody who receives a risk score will be a Medicaid enrolled individual over 21 years old with a physical disability. So that kind of isolates the population that will get the risk score. And then, as I mentioned earlier, the components that are included that could increase or decrease your risk score are listed out here. Age is one of them, whether somebody has a partner. That is one of the elements that we have in our data that connects to different living arrangements. If someone had previous nursing facility stays, multiple hospital visits, or inpatient stays. chronic conditions like diabetes, serious mental illness, stroke, and dementia were some of the factors that we were looking at. As we continue to work with the monitor and the DOJ on this, some of those things may stay in the model, may be adjusted out, but in our initial work, those were some of the factors that were identified through the stakeholder engagement and literature review that we included in our model. I'll hand it back to you, Victoria, to talk a little bit more about the process.
Thank you, Joe. Okay, so agency roles, transition coordination has expanded, like I just mentioned earlier, their eligibility benefit to any Medicaid member that is living in the community and who is identified as at risk. And these people will need a higher level of community-based support to manage extreme life changes. It can also be to support to find or maintain housing or other community resources. So CMAs and RAIs will now be able to send referrals to TCMTC for these members that are identified as at risk, the members that are on this list. So really step one, once they receive the list in this process, the CMAs or the RAIs, is the at-risk members and their chosen supports will receive an additional outreach by the CMA or the RAI to evaluate and or to redetermine the member's services, needs, resources, and any potential need for like additional supports and services or referrals. And these things are to mitigate risks and to assist them, in keeping the members safe in the community. The TCs will not change any of their current processes. We're not asking the CMAs or RAIs to change any of their current processes either. They will still provide the same support and services to members that they're currently obligated to do. So what does this mean? We don't want any duplication of services. So referrals will only be made to TCs when the member's needs or supports or like additional services falls outside of the CMA or the RAIS scope of work. There's going to be a referral process for CMAs and RAIS to send referrals to TCs. Nora's going to actually present after me, so she's going to provide a little bit more details on that piece. So I won't talk about it too much here. We can actually go to the next slide. So the start date and implementation of at-risk. The department will distribute the first list after January 31st. We're aiming towards probably February or March of this year, just depending on that approval that Jill had talked about earlier. And there will be an advance notice to all agencies involved prior to this list distribution with an exact date. That this is going to occur. So we're just not going to like throw it on everybody. There will be advance notice once we do have a hard date set. I just want to throw it out there that it possibly we're aiming for February or March. At-risk lists will be distributed to both RAIs and CMAs quarterly. And the department does plan to implement a much smaller list than previously expected. So the first list we're looking at about 200 to 250 members statewide. To be divided between the CMAs and RAIs. And then, so with that, there will be a smaller number of people because the list is much smaller. So it is very possible that the number of referrals that are going to be going to TCs could potentially be much smaller in the beginning as we roll out this project. I want to mention that the at-risk referral form is only going to be available to members that are on this at-risk list. Members, individuals in the community, agencies, RAIs, TCAs, CMAs will not have the ability to make a determination about who is and who is not at risk at this time. So the lists will be requested by the department and they'll be distributed by the department. And at this time, the department's using the list as its main source of determination of the at-risk members. So another thing I want to quickly talk about is we get a lot of questions regarding community referrals, those referrals for individuals that are not on this list. And we're aware that circumstances and things that happen that can put an individual at risk for institutionalization. And we are currently working on a second phase and developing an official outside referral process that will include specific criteria We're still working on the details on how that can or how it's going to work. We don't have anything like set in stone. Like I said, it's still a work in progress. So more details about this, the outside community referral. We don't really have a name for it yet. So, but that process will be shared in the near future once it is approved and complete. And again, this is a new process. The department wants to be responsive and partner with each of you as changes are needed or made. The department will continue to review and evaluate ways to improve accuracy to ensure that members most at risk of nursing facility placement are reached. And we are excited to pilot this project with your support. And then my contact information is here. So if anybody needs to reach out to me directly, or if you have any questions, please email me. And then also I did plug in the website. If you want more information on at risk or other projects that our team is working on, they are on that website. So I am going to go ahead and pass it on to Nora. She's going to be speaking and talking more about the at-risk diversion services.
Hello, everyone. I'm trying to get my camera to work, and it's not cooperating with me. All right, we'll forge ahead anyway. So I first want to mention that this TCMTC at-risk diversion training will be scheduled for TCAs later on in the month. So this is a kind of mini version of that training. Next slide, please. So targeted case management diversion services will include, will certainly provide a level of support for those individuals who need housing or a change in housing. And so we would collaborate as needed with the housing navigation services to obtain a voucher and locate housing. We'd coordinate with property managers regarding housing issues, create a transition budget with members, facilitate a community-based living arrangement, obtain and assist with required documents necessary for the voucher application and leasing applications, and interagency contact and coordination with our HCBS case managers and RAIC coordinators will be essential. So this is not anything new or different. This is what we do for our transitions from nursing facilities. So that process will not change. Next. So there will be a TCMTC at-risk diversion referral form, and that form will be completed by CMAs or RAIs, and will include the member information, the referral source, the date that at-risk was determined by the department, if there's a TCA preference, the county, desired housing, and member needs. So a pretty basic referral form. Next slide, please. There will also be a at-risk diversion plan that will be required, and TCs will have 7 business days of the referral acceptance to complete that. So in terms of your first meeting with a member and then having this plan developed, the timelines are not the same as your regular transitions from a facility. So because they're at risk, we want to be able to meet with the member as soon as possible and start the process that's needed to support them and help them stay out of a nursing facility. So it's going to be very important to complete this diversion plan. There'll be a risk mitigation plan embedded in the diversion plan. It's a streamlined risk mitigation plan. So it will not be the same format as the plan that you use for transitions from facilities, but the risk mitigation plan and the diversion plan will document issues related to the at-risk status, housing preferences and needs, community supportive services, and it establishes a plan to avoid facility admission and stabilize community living. And again, this is all done in close collaboration with the CMA and the RAE that are involved also with this member. Next slide. So what are the expectations for the TC? You will complete all required trainings and follow protocols. Nothing new about that. As I said, we will schedule an at-risk training for TCAs in the next few weeks. You'll conduct activities within the required time frame. And again, it's a quicker time frame than what we're accustomed to. And this is really important. The TC must review the CMA CCM documentation related to the at-risk referral prior to meeting with the member. And that's going to be very, very important because that information is going to inform your diversion plan and or your risk mitigation plan. You're going to ensure that TCMTC documentation aligns with training guidelines, and you're going to follow protocols for ending TCMTC services. Next slide, please. So this is the diversion process. I'll just walk you through it quickly. The CMA and the RAE completes the at-risk outreach and determines the need for a TCM. They then will complete an at-risk diversion referral form to TCMTC, and that referral form will be sent to the transitions administrator here at HCPF. The transition administrator will send the at-risk diversion referral to the TCA. The TCA has 1 day to respond to that referral. And once the TCA accepts the referral, they have 2 days to meet with, 2 business days to meet with the member. At that point, your TC is going to review all of the CMA information related to the at-risk status and or the member's situation. TC will complete a diversion plan with the member and their support network. The TC has 7 days to facilitate the completion of that diversion plan. The diversion plan will be uploaded to the CCM activity log screen. TC diversion activities will be provided until the diversion plan is completed and the member's risk level is medium or low. And at that point, TC diversion services are closed. And I just also want to reiterate that TCMTC services will be provided for when there's a member who has a need that the CMA or the RAE is not able to respond to. So if they have a higher level of, they need a higher level of support in the community as they're moving through this major life change, then TCMTC would be the service that would provide that support. Next slide, please. I don't think we're going to do questions now, but my contact information is here if you have any questions. And for those TCAs that are in this meeting, I know you're going to have lots of questions, but again, we're going to do a more comprehensive training in a few weeks. And at that point, we can certainly answer all of your questions. And now, where does it go? To Deborah or Susie.
Actually, Jay, I'm wondering, do we have enough time for a few questions? Since I know it's kind of a lot related to the at-risk work, could we take 5 to 10 minutes to answer any questions?
Yes, we do.
Okay, awesome. But yeah, let's open it up. If anyone has questions about the process, the goal, the modeling. No questions? Okay.
Sorry, this is April. I have a question. So, how are we going to know? So, if a Ray or a CMA cannot do, it's outside of their scope. Like, how would we know that? What is their scope, and what can they do?
So,
Just so that way we could be on the lookout for.
okay, that's a great question. And I think that, we've had that a lot too, like, other people asking those questions. So it's really going to be two different. If you think about what Rays currently do, they pretty much do a lot of the same things that that you guys do. The biggest part with the Rays, I think that they don't really do as much of is probably the housing piece. They can help with like a budget, and they can, have their peer support maybe help, like, with a member with the budget and maybe filling out an application and things like that. But they don't really have any resources for like the housing piece, housing vouchers, helping them find housing, things like that. I think for Raise, the biggest thing that they have is probably like giving them resources. Um, so Raise do a lot of the same. So when you get the referral, there should be an indication of what the member needs help with. Now, as for case managers, I will say that um, they have probably a little more limitations on how much hands-on work and support that they can help with a member. So you might get somebody with like complex that needs like more complex help or more complex hands-on assistance, like filling out those applications, maybe advocating for the member, going and helping them find housing or talking to a landlord or things like that, helping them fill out like maybe a food stamp application, those things that you already do. But case managers, that falls outside of their scope of work and how much they can help. They do have their required contacts, but it's probably not going to be as much as, especially if somebody needs that higher level of support, it's not going to be as much as what you guys could offer. Now, going back to the Rays, they can offer, monthly or more than monthly meeting with a member. So sorry, long answer, but it's really going to depend on the situation. It's going to depend on the individual. You will get the information on the referral form. It's really just going to depend on that member's situation. But I will say, when it comes to Raise, it'll probably just more than likely be about housing, needing that housing support. Case managers, you're probably going to see a little bit more hands-on assistance that they're going to need help with. I hope
Okay.
that answers your question.
Yeah. Thank you.
Yeah, and I would just add, April, that if you get the referral, then you can provide the support. We want the Raise and the case management agencies to do as much as they can do to support this member in connection to services. But if the member needs additional support, they'll make that referral to you all.
Got it. Thank you.
Yeah.
So
Jennifer?
when Victoria and Jill are saying you all, it's the TCA she means. I think April is the options counselor.
Oh,
Yes.
Yeah.
sorry about that.
That's
Nope.
okay.
Thank you, Nora.
And I saw that LaShawn had a question, what's the compensation? For TCMTC diversion, it's the same compensation as for all TCMTC services. So there's no change there. And the number of units available won't change either.
Thank you,
Jennifer?
Nora.
Thank you.
I see Jennifer, your hand up.
Hi, yes, this is actually Tiffany. Sorry, one second. Hi there. So sorry. A little bit of a Zoom mix up there. I was just wondering if the local contact agencies and options counselors, like where do we really fit into this? It doesn't really look like we're part of the process, but I wanted to make sure I fully understood.
Yeah, you're right. Yeah, I would say the majority of this is probably going to be the members are identified, they're going to be distributed to a case manager or to a Ray. And then, if they need that level of support, then a referral would be done to the TCAs.
Yeah, I think where Jennifer potentially in the future you all could come in would be as we develop that referral process, sharing your experience there on the components that drive people to nursing facilities, or just having the general awareness that this program is available, especially once that referral process opens up as well, so that you can connect people that you may have stayed in contact with in the community to that if they end up needing it. So you're right, it's not directly related, but we did want to make sure that you all were aware of this as well. Great, any other questions? Good question, Amy, in the chat about will there be opportunities to tweak the algorithm as this is developed, as we receive the data? Absolutely. This is it's a new process. What we're going to do is on an annual basis, go back and review and see, okay, here was the folks that we reached out to. How many of them ended up in a nursing facility? How many people that weren't on the list ended up in a nursing facility? And are there adjustments that we could make to the algorithm to really try to outreach people the most at risk? So yes, definitely something as we keep getting into it that we want to learn from and adjust the model. As part of the DOJ agreement, as we do that, we'll have to go through the approval process again. But we want to make sure that we're outreaching folks that really need the support. So yes, great question.
And Jill, there's a question about when this is going to be implemented.
Yeah, and so for that, as Victoria said, it kind of depends. So we're working through the approval process with the DOJ and the monitor. We've trained the case management agencies, have been having conversations with the Rays. Our hope is that we'll be able to send out that first list in late February or March. But depending on when we have that approval, will really determine when we can start the outreach. So I would say springtime to be safe.
Hey, I'm sorry, I can't find my hand to raise it, but I do have another question, and this is more for Nora. I have a member who reached out that's in a nursing facility. It's a life care nursing facility in Parker. I sent them the information for options count. They went through the process, but options counseling told them that they're not in a I guess a approved facility in order to get the services. So the gentleman called back and said, what do I do? I'm going back. He has a home, but it's not suitable for him. So he's going to end up back in a nursing facility.
So if you send me that person's name, I will research it. And then I'll work with our InReach team to make sure that we get education out to everyone about appropriate referral agencies and facilities.
Thank you very much.
Sure.
Okay, well, thanks, Jay, for taking a pause in the agenda for some questions. Just wanted to make sure we could clarify any points that anyone was curious about. So I think we can go ahead and move on.
Yeah, no problem at all. I think that was perfect timing. And we can go right into the transition escalation updates. And I think Susie was going to do that.
Hi, everyone. This is Susie Bachler. I am an InReach counselor in OCL, and I'm standing in for Andrea. And I'm just going to make this short and sweet. And LaShawn, your question was actually a great segue to this because this is a good example of an escalation. This December, early December, Hick Puff and our team specifically began implementing the use of Salesforce to manage transition escalations in an effort to streamline the handling of questions and concerns that come up in your daily work. This process applies to both long-term care transitions from institutional settings to home and community settings, including escalations pertaining to housing navigation and Cat V voucher administration as well. I had a great email from Dr. Cog, and I apologize for not answering that yet, but you asked how this applies to options counselors. Specifically to you, it would be things like SNF interference. And when you're setting up your group in-reach meetings for transition coordinators, it could be SNF interference as well. Perhaps you're not getting the documents you need from the SSD at a facility. You would put in that escalation request using the new web form link that we'll drop in the chat to let us know that there's an issue so that there can be another set of eyes and someone else to help you mitigate that issue.
So Susie, I
Yes.
just want to add in that options counseling agencies are often contacted by nursing facilities because they have concerns about a transition process, or a resident has said they want to change TCAs. So those sort of things would all go into our escalation mailbox as well.
Right, and I did send that information to all the SNF SSDs and NHAs as well to let them know that this was our new process. And I sent them just a quick update about things that they could put into the web form, including that. For example, someone would request to work with a different agency, things like that, or when they feel the communication is lagging to some degree. So because this process is new also, we don't have a defined list of what all those escalations are going to be, but we are creating a living document that will capture a lot of those, and we'll be sharing that with you as well. The web form is really easy to use. Fill out as much as you can put in there. Next slide, please. And I also forgot to mention, just submit one ticket per incident or issue so that it makes it easier to track. Someone on our team then assigns it to the appropriate person to address that need. On this slide, it shows priority levels. You don't have to choose that. That again is the person on our team that will be assigning it to the appropriate person. The timeline that we have, once you put that ticket in, it starts on that day, unless of course the ticket is submitted outside of our office hours. In that case, it'll begin the next day. Holidays don't count. But again, this is an effort to make sure there's more than one set of eyes on things, and so that we can streamline this process, do reports that we need to, so we know where there's training needs associated with something, where there's a consistent issue, things like that. And let me go ahead and drop that web form into the chat so you can take a look at it at your leisure.
While you're doing that, Susie, I just want to tell everybody who's on the team that you're referring to. So the team includes members of the InReach team, the transitions administrator, me, and the HICPUF housing team. So Christine Dos Santos. So we'll have, subject matter experts who will be able to respond to anything you all send us.
There is a note. Is that Rhiannon? And it says, hi, the web form link is difficult to navigate for escalations for community members. Is there any formal guidance on how to properly fill out the web form link that I can pass along? I don't believe we have anything right now, but we can certainly do that. And I agree with you. And because this form is used for a lot of different departmental needs. So thank you for that, Rihanna. I'm going to take a note on that. And that was the quick and easy of this. And Nora, thank you for your input. Does anyone else have any questions that I can answer? Going once, twice, and you don't have to raise your hand. You can just come off mute.
Susie,
Yes.
one thing that I would add is, and maybe you said this already, so I apologize, but is that this web form is also used for eligibility and case management escalations as well. So, if you know that you're having a financial eligibility or a functional eligibility issue, feel free to choose those options as you're filling out the form as well. And that's kind of one of the reasons why we wanted to use this Salesforce process, is that we know a lot of times when there's an escalation, there are multiple issues or multiple concerns that need to be addressed. And using this process will allow us to move that ticket between the county team, between the case management team and our team, to hopefully resolve those issues much quicker. So just a quick flag there.
Yeah, no, that's great input, because we did see a lot of that when we went into the facilities. So this could be another, for the options counselors that are on the call, this could be another touch point to train new SSD staff that's available for that as well. We did see that a lot when our HICPUF team went out to do group and reach. We had a lot of questions about eligibility at the time, and a lot of people did not know that this web form existed. So that great point. Thank you, Jill.
It looks like that Maria has her hand up.
I do. Thank you. This is Maria Stepanyan from Center for People with Disabilities. Thank you for all the information and for mentioning what you mentioned, Jill. I have a clarifying question. I want to understand, is this an escalation after the number of days that counties have for this specific example? For example, the counties and eligibility, generally they have 14 days to respond or to process the paperwork we have submitted. So would we be able to submit for escalation earlier than the 14 days, or do we need to wait until the days they have? And if it's not processed within the required days, then we do an escalation. I want to clarify that piece, please.
Yeah, thank you. Yeah, thanks, Maria. That's a good question and good for us to clarify. So this is for escalations for cases that take longer than what is allowable. So in that example that you used, it would be, you could escalate it on day 15 for those situations. The other thing to keep in mind is that, we ask that you go through the regular channels. So trying to get a hold of the county or the case management agency, start there, because that would be the fastest way to resolve the issue. And if you're still running into trouble, if that part is taking too long, then absolutely fill out this form so that we can step in and help out. Yeah, thanks for asking that. That's a good clarification.
Thank you.
There is another question from Lisa. It says, just for clarification, this can be used for issues with a member that is having interference at the facility level that is not allowing members to transition. Absolutely. Yes. You can also put what we ran into just recently were POA guardian issues. And for example, a lot of times staff use those terms interchangeably. They're not the same, right? We want someone who doesn't have a legal guardian, but the POA doesn't want them to go on to the transition portion to talk to a TCA. Well, unless they have a legal guardian, that shouldn't be the case. So that's one instance of something that could be escalated using the form.
So Susie, I'd also just like to say to the TCs who are listening, any issue that you would send me an email about that's related to a transition, you should go ahead and use the escalation form now.
Right, good
Because
point,
as
Nora.
Susie was saying, this will give us a great opportunity to track information and to identify patterns that maybe the department can step in and resolve. So just think of it that way.
Right. So, and great point, Nora. So anything that you would typically send to one specific person on our team, please always use the web form link so it's in one place and multiple people have eyes on it. You can, still feel free to send an email saying, "Hey, I filled out this," if you need to make sure that it went through or something like that, but please always use the form as opposed to emailing one specific person. Then there is a question from Jennifer, Dr. Cog. Are LCAs meant to use the online form to report any or all SNF interference in addition to our regular reporting on group in-reach interference? So I think what you might be referencing is in the tracker where we ask you to report for your specific visit to a facility, we had that tab going. That was previous to us having that. You can capture the notes like while you're maybe at the facility that there was an issue, but then always please do add it to Salesforce. Am I answering your question, Jennifer? Okay. And then Jennifer, like I said, thank you for that email. I'm going to respond to that and send it to all of the options counselors so they can see the response to that, because I think it's great questions that everybody should see. Any other questions? So I guess my final closing statement, anything that you think is an issue, put it in that form so that we can help you address it. Okay, Jay, back to you unless there are any other questions.
Thanks, Susie. And this time is open forum, so for any and all questions. And I see that there's a lot going on in the chat. So if you're not following along there, some of your questions may have been answered there. There is a response from Chanel that kind of covers several of the questions that came up. And she says that the group in-reach form was created prior to the process for the form we were just discussing. And we would like it to be, we would like it on the escalation form for tracking. It may also be helpful to give us a note on the group in-reach deliverable so that we can pair them together, but the form is the preference and it's going to be designed to supersede the previous process. So all that's in the chat if you all want to follow along, but it looks like all the questions were answered there. And Chanel, apologies if I butchered that and did not say that correctly, just let me know. And right now it's just open forum for all questions, comments, feedback.
Thanks, Jay. To open our forum, I did have one question that I wanted to reach out and ask about. As Jill stated, we have our DOJ monitor, and she'll be coming around kind of doing some visits. I know that she's met with a few of you ongoing, but she will also be here the last week of January. And so we were actually looking to see if there are any volunteers from the local contact agencies that are completing a group in-reach on maybe the 30th of January, and she could come along with Jill to shadow and just kind of see what that process looks like. So I just wanted to open the floor up to see if there are any volunteers that would like to do that with us. And you don't have to answer now. If you want to reach out to Susie via email, if you have some questions or anything like that, before you make a commitment, we are more than happy to answer those. And I just realized my camera is not on because my thing is closed. So sorry about that. Let me fix that. Sorry. Hi, everyone. So yeah, if you or your agency is having a group inReach during that time period, we would love to come out and sit with you and kind of see how that process is going along with our monitor for the Department of Justice findings or agreement. So.
And Jennifer from Dr. Cox said she will keep us updated on potential meetings on that date. And then Chanel, I will also let the grantees know if any of them fit that criteria as well. The MFP capacity grantees.
Yeah, thanks everybody for helping with that. There will be other times as well. I know our monitor, Melanie, will be here, over the next 3 to 4 years, multiple times. So we can pull her into some of those other group meetings if we're not able to for this next visit. So thank you for that.
And what were those days again, Janelle? I'm sorry, Chanel, what were those days again? January 30th?
Yes.
January 30th. She'll be here the 27th through the 30th, but we are looking for group inReaches on the 30th as the rest of the schedule's kind of built out. Right, Jill? I said that correctly? I'm just remembering off the top of my head, so.
Yep, you got it.
Okay. We had a question in the chat, so I just wanted to confirm. Also, just another reminder, our next TSAC meeting will be on February 6th at 2:30 a.m. Or 2:30 p.m., sorry. If you do need that link to re-register, since this is a new year, just let us know. I can drop that in the chat as well. Go ahead, Maria.
Thank you, Jay. I have a question. I wonder if this would be appropriate time to ask about the diversion services that was presented on at the beginning of the meeting. Can someone provide a couple of examples of what the services would look like? It's a little unclear to me. What would the TSA specifically provide? What type of services? In real life examples, if you can share a couple of services we would provide once once a consumer is referred to us for diversion services. Please.
Yeah, I'll give you an example. So let's say a member is assigned to the RAE. The RAE contacts the member. They offer care coordination. They do their assessments. And as they're going through, asking them questions about, resources, if they need any additional support, they're going to ask a housing question, if the member has stable, appropriate housing. Let's say, for example, the member is unhoused. And let's say the member needs help with creating a budget. That falls outside of the scope of work of what Array can help with. They don't have housing vouchers available to them like the TCAs do. So in that case, they would make a referral to TCA. It'll have an indication on the referral form. This member needs support with housing, list everything that goes along with that, and then they would make that referral. And then TCAs would, like Nora was talking about the process, the days they have to accept the referral, start working with a member, and then they'll work through their process.
I can add to that also, Maria. This is Nora. So if you think about our post-transition monitoring, we're able to provide a higher level of in-person monitoring. And our services are in the home. and they're as often as a member needs them based on their risk level. Array provides support, but they might not be able to provide support in the home as many times a week as the member needs it. So I would, think about it in those terms. Post-transition, higher level of monitoring to address risk levels.
That helps very much. Thank you.
Sure.
Thank you. That was a great question. Does anybody else have any other questions? Well, I don't know if you guys saw it, but it looks like there was a taker on Chanel's question, maybe. I don't see anything else. And it doesn't have to be about diversion. It could be about escalations too. Just kind of want to, right, or if anybody has anything they want to talk about.
Thanks, Victoria. Yes, and we did have a question about the access to the materials in the chat, and we will work on getting that updated, Jennifer. And thank you, Chanel, for responding to that as well, so that you guys can all have access to the slides and all of the great information that is presented during these stakeholder meetings.
I am going to drop in the chat that website that I had on the slides. So this website is, it kind of has a little bit of information on all the different projects that our team is working on. You'll also find information on at risks. So we're going to try and update it, like, as things come in, and just anything that comes in, new information, new documents, anything like that. We're going to work really hard to get all that updated and put in there. But you guys are, that's going to be a good source of information if you want to kind of know a little bit more about what our team is working on. And that's, that's going to include the individual inReach, the group inReach, escalations, diversion, housing, everything going to be in there.
Okay, well, that was all for our agenda today. So if we don't have any other questions or comments, we can close, but I will give it a few more minutes just in case any last minute thoughts come through.
And then I think I just wanted to add, the plan for our next meeting is that we'll have someone come and speak about CDAS and IHSS. I think I said that correctly, just to kind of give us that as an additional option for members who are transitioning, and talk through that process. And then I just want to offer that we are open to suggestions or any additional like training or information that you all feel like would be helpful as you support our members. So just keep us posted, send us an email, set up a meeting with us. We really want to make sure that these meetings are beneficial to everyone who's attending, and that we're sharing information and providing a space for you all to collaborate and kind of have those conversations and get questions answered. So please let us know what else we can do to support you all. With that, thank you all. Have a good week.
Thanks, everyone.
Thanks, everyone. Happy New Year.